This is Andrew Schmidt. I'm an assistant professor of emergency medicine at UF Health Jacksonville, deputy medical director of Trauma 1 Flight Program, medical director of Jacksonville Beach Ocean Rescue, and director of Lifeguards Without Borders. I'm here to talk to you today about drowning resuscitation from the physician standpoint. To understand where we are today, we need to get a better understanding of where we come from. This is the first depiction of a drowning resuscitation from 1237 BC. What it shows is the king of Aleppo, outlined in blue, surrounded by his guards. During a battle, he fell into a body of water, and his guards held him upside down in an effort to rid his lungs of water. As we go through the centuries, we see literature showing a person on the left holding a victim in front of a fire. The idea behind this is that fire and smoke are stimulants, so if you can hold someone from a fire, it might stimulate life. In the bottom right, we're also seeing very early forms of Heimlich maneuver in CPR, where a person was thrown on the back of an animal and the animal would run around in a circle, therefore providing compressions to the chest and the abdomen. Now here is everybody's favorite. This is the tobacco enema. Again, the idea being smoke is a stimulant. Well, how are we going to get smoke into someone if they're dead? Well, we shove a tube up their butt. This was the original origin of the term blowing smoke up someone's ass, and was originally used for drowning patients. This was a depiction from a 1946 Popular Science magazine. What it showed were very early forms of CPR known as the Schaefer method. And also on the right side, the lifeguard who had enough time to build a simple machine on the beach would rock the patient back and forth, again in an effort to rid the lungs of water. So you may ask yourself, why do we still talk about this? We have all this fancy equipment like fast boats, we have robots and drones that can get patients, we have things like Lucas devices, we have ECMO, every drip medication we could possibly think of, so why do we keep talking about this? Well, the problem is that an estimated 91% of worldwide drowning deaths occur in low and middle income countries. They don't have the education and they don't have the resources, so it's a much bigger problem outside of our own borders. Also, no matter what education resources we have and how far we've come in medicine, today we are still seeing scenes like this right here. These are well-intentioned military guard who have pulled a child out of the water, and their first course of action is hold the patient upside down and try to get water out of the lungs. This is no different from the treatment provided to the king in 1237 BC. Here we're seeing a patient held above a fire. If you watch this entire video, there are about 6 or 7 patients who fall off a capsized boat, and the very first thing that the people on land do is build fires for each and every patient. Again, this is what their culture shows, this is what they've been taught to do, and without outside resources and education, they aren't able to improve their practice. No different from the depictions we saw centuries ago. Here we see a police officer picking up a child who was just pulled out of a body of water. Now their first efforts are to put the child on their back and run around in a circle. No different from the depictions in the literature, showing it on the back of an animal. And every time I show this, I like to say that I don't show it to demean what the rescuers are doing. They're trying to do the best they can. I guarantee you at some point they did this and it worked, and it became the standard. And you can see how dangerous stagnant protocols are when you don't build off new education and information. And here, very inefficient poolside CPR being performed, a person not knowing the goals of treatment for a drowning patient, and probably as effective as building that simple machine on the beach. You'll probably have the same outcome. And lastly, the only video I could find of blowing smoke up someone's ass. I guess fortunately, we aren't able to see this in current form of treatment. So, the numbers. What kind of burden of disease are we talking about here? Well, first off, there's an estimated 372,000 deaths globally every year from drowning. Now, this is a gross underestimate. It does not include natural disasters, or mass casualties, or suicides or homicides. Also, it's dependent on very weak data collection. Like I said, 91% of drowning deaths occur in developing countries. Many of these countries do not have a good form of data collection for drowning deaths. We're talking about the United States is about 4,000 deaths per year. And in Florida, it's about 400 deaths per year. Now, all over the place, it's worth noting this is a disease of children. Yes, it affects all age groups, but especially in the U.S., the 0 to 4 age group has a huge burden of disease and mortality when it comes to drowning. So, terminology. It's very important for us to be speaking the same language. Just as you wouldn't want to go to different doctors and have each one have a different definition for what diabetes is, we don't want different physicians and practitioners having a different definition for what drowning is. So we've all heard different terms, mainly near drowning, wet, dry drowning, secondary drowning. We've heard dry drowning a lot recently in the news. But what does it all mean? Well, in 2005, a paper was done out of University of Florida in Gainesville. In over 60 years of drowning literature, they found 33 different definitions for drowning. This is variability that would not be accepted for any other disease state and should not be accepted for drowning either. To help improve this, in 2002, the World Congress on Drowning met and came up with a uniform definition for drowning. And what that definition is, the process of experiencing respiratory impairment due to submersion or immersion in a liquid. Now, this primary definition can only have three outcomes, either injury, no injury, or death. So you see that this definition has nothing to do with outcome. It has nothing to do with whether the patient lived or died. That primary definition, all it says is the patient's airway dropped below the water, and because of that, they experience respiratory problems. From there, there can be injury, no injury, or death. With this definition also came the recommendation to discontinue the use of any confusing modifiers like near, wet, dry, active, passive, secondary, or delayed drowning. These modifiers only serve to confuse the discussion and do not fit within the realm of the uniform definition. Unfortunately, every month we're still seeing this in the headlines of literature. We're still seeing terms like near drowning and terms that don't fit within the uniform definition of drowning. To show an example, we did a systematic review of the literature from 2002 to 2010, so the 8 years following the uniform definition. Within that time period, we found that 43% of the literature that we looked at, this is all peer-reviewed literature in very high-caliber journals, 43% still had terms that were not within the confines of the uniform definition. 97% of this was due to the term near drowning. When we are now publishing a follow-up study, so 2010-2015, still finding 30% of the articles we looked at have non-uniform drowning terms. So an improvement, but still a long way to go. So the drowning process, it's not so important to understand the steps of the drowning process, and no one can really hammer out the exact steps as long as you understand the final outcome. So in general, someone submerged underwater, they struggle for a certain amount of time, they hold their breath for a certain amount of time, and at some point their brain says, hey, I need oxygen, and they take a breath in. Now they may or may not aspirate water, but that's not important. It doesn't change anything clinically. What's important is that they have airway obstruction leading to hypoxia. Again, as long as you understand that hypoxia is the end result, it doesn't matter what the pathway to it is. Hypoxia is the primary cause of all systemic injury and death associated with drowning. It has to be the focus of our treatment. As long as you keep this in the back of your brain when treating a drowning patient, you're going to do the most amount of good. So change your thinking. We always think of drowning as a lung disease. We always worry about the lungs. If the patient makes it to the hospital, we can treat the lungs. We cannot treat the brain. So drowning has to be seen as a brain disease. Time is brain. We need to reverse the hypoxia and save the brain. So initial drowning resuscitation treatment. Now when I talk, I always weigh a little heavy on the EMS side. This is for a couple reasons. Physicians are often going to find themselves out in the field, in the ocean or around a pool, and are going to have to treat a drowning patient. And I want them to know what to do without all their fancy equipment in the hospital. The other thing is the most amount of good is done in the first 5 minutes. Our lifeguards and EMS personnel can have the biggest influence on patient outcome when it comes to drowning. Once they hit the emergency department or the ICU, the damage is done. So I want you to understand the primary focus of treatment when treating a drowning patient. So like I said before, hypoxia is the primary cause of systemic injury and death. So how do we treat that? We give oxygen. We give it any way we possibly can. We give mouth to mouth, we give mouth to mask, bag valve mask, whatever you have, you give it to this patient. I like to call this my dumb slide, but I think it makes the most sense. 21 is greater than 0. 21 will always be greater than 0. What these numbers represent, 21 being the concentration of oxygen in the ambient air, and 0 being the amount of oxygen the patient's getting if they're not breathing. So whatever you're giving this patient is better than 0. If you're giving them mouth-to-mouth, 16%, better than 0. If you're doing a bag valve mask without oxygen hooked up, 21% greater than 0. Whatever you can do for these patients, give it to them. Don't wait for the fancy equipment to come around. be that person that gets to the patient with a bag valve mask or some other device, even if you don't have supplemental oxygen yet, and start getting ventilations in the patient. So here we see kind of our typical severe drowning patient. So what we see coming from the mouth are a couple things. So it could be vomitus. So again, the person was trying to save their own life, so taking lots of gasping breaths, probably distended their stomach, but also foamaceous material. So when surfactant and water mix in the lungs, it makes this foamy material. So this often scares people, and when they come up on a patient, they kind of revert back to their textbook learning. And what that always told us was you need to suction 10 seconds, reevaluate the airway. If there's still foam, suction 10 more seconds, reevaluate. If they're still having stuff in the airway, roll them over in recovery position. The problem is while you're doing all this, the oxygen saturation is continuing to drop more and more and more. And these patients are already starting low. So we can't let these maneuvers get in the way of providing oxygen to the patient. You don't want to try and remove the foam as it will keep coming. This is in the recent European Resuscitation Council guidelines. Again, this isn't a quick process that'll stop. If they have lung injury, it's going to keep coming out. So what we need to try to do is actually bag through the foam or ventilate through the foam. Mouth to mask, whatever you have, try to get breaths through the foam. Often you can get a couple breaths, and it may be the difference between the patient going into cardiac arrest and not. If you cannot get any breaths, then yes, we need to do some sort of maneuver to clear the airway. Whether that is suctioning or chest compressions, whatever the algorithm calls for at that time. But first off, try to get some breaths into this patient. Next thing, we really need to differentiate the two types of cardiac arrest. This patient here, he was walking down the beach. He hasn't taken any of his meds all day. He was on his third run of Taco Bell. He clutched his chest and collapsed in the sand. What probably happened to him was probably a cardiac cause of his cardiac arrest. This has to be differentiated from this patient, the drowning patient, which is a respiratory cause of cardiac arrest. They're two different beasts and they cannot be treated the same. For the cardiac cause, I like to say his tank was full, the engine is broken. So up to the point that his heart stopped, he was breathing and had pretty good oxygen saturation. So he had a full tank of gas, but then his engine broke. So he doesn't need gas. This is where compression-only CPR comes into play, because these people can hold their sats pretty well in the first couple of minutes. So we really need to be their engine for them. This is different from a respiratory cause. Their engine stopped working because the tank is empty. They ran out of gas. So we can't just do compressions, we have to refill the tank. So that's why ventilations take priority in these patients. This is outlined way in the back of American Heart and also in the European Resuscitation Council guidelines, saying CPR for drowning victims should use the traditional ABC approach in view of the hypoxic nature of the arrest. This gets overlooked a lot, especially when we're developing community CPR programs where we're really pushing compression-only CPR because it's fast and easy, but forgetting to tell people, hey, if you're around kids or other people that may suffer a drowning incident, you need to be able to be trained in traditional CPR with ventilation, because that's the only way to treat drowning patients. Also, if you look at the rhythms, in our cardiac arrest patients, the most common rhythms are going to be our VTAC and VFib, and we treat these with electricity and compressions. Well, the most common rhythm in a drowning patient is going to be asystole in PEA, and we treat this by reversing the cause. The cause is hypoxia and compressions. Next, spinal immobilization. All these patients tend to get spinal immobilization in the field for a huge fear that they may have suffered a C-spine injury. The evidence that we have shows a very low prevalence of C-spine injury in drowning patients. And the problem is that the spinal immobilization often gets in the way of proper resuscitation. We've seen videos where rescue teams spend 10, 15 minutes fully packaging a patient who doesn't have a pulse, when what they need is oxygen, CPR, and rapid transport to the hospital. So again, very low prevalence of C-spine injuries. The one that has C-spine injuries usually have clear signs of trauma, altered mental status, intoxication. Someone saw them fall from a height or dive head first into a pool. But the ones that are talking to you, not complaining of any symptoms, we can use our Nexus and Canadian criteria and not fully package these patients. The main thing is this should not delay resuscitation. Reversal of hypoxemia has to be first and foremost. Abdominal thrust, also known as the Heimlich maneuver. These should not be done in the initial resuscitation or in any part of the resuscitation of a drowning patient. They were initially pushed very hard by Dr. Heimlich himself. He had evidence that he showed improved outcome greatly in drowning patients. Unfortunately, all this evidence was found to be falsified and not true. Since then, all the major health organizations have come out and said, do not use abdominal thrust in the immediate resuscitation of a drowning patient. All this does is delay needed ventilations. Unfortunately, there are still water parks in our country who have this in their protocols. So if you're on scene treating a patient and you have someone come up to you and say, do the Heimlich maneuver, again, be confident, say, no, I need to reverse the hypoxia of this patient. I know what I'm doing. So how do we classify drowning patients? There's been attempts at multiple classifications in the past, but it's good to have some insight into the big one that's going on right now and has the best amount of evidence behind it. It's nothing to ever memorize, but it might help you make a disposition. So this is Dr. David Spielsman. He was the medical director for the Drowning Resuscitation Centers in Rio de Janeiro, Brazil, and he has a huge database. Back in '97, he went off of 41,000 cases, and of that, he used 2,000 cases which required care and did some retrospective studies on those to find out what initial physical exam findings led to disposition. And from that, he made a grading system, which we're still using today, and we're seeing a lot of papers right now. Now, grade 1 was where the patients would maybe a little bit of cough, but no foam, lungs were clear on auscultation. These patients ended up having 0% mortality and able to be released with education. Grade 2 and 3, we started seeing small foam from the airways, mainly started seeing abnormal lung sounds. So that meant early lung injury evidence in the patients. As you can see, mortality started jumping up. Once we started getting large foam in the airways, mortality went up to 5%. Again, very hard to discern small from large amount of foam, but just knowing that foamy material, abnormal lung sounds are showing early lung injury. These patients would be best treated in the hospital with oxygen treatment. Grade 4, we started getting hypotension. So hypotension as a marker of hypoxemia, and we see that our mortality jumps up to about 20%. And 5 and 6, respiratory cardiac arrest. If someone comes in a respiratory or cardiac arrest from drowning, it's really pretty poor outcome. So a patient comes in the emergency department. How are we going to care for them? First off, prioritize establishing ventilation, optimizing oxygenation for the patient. So always ABCs first. Patients who are protecting their airway and maintaining well, we can just do non-invasive measures. We can do nasal cannula, non-rebreather mask, really just aiming to keep their oxygen saturations up 94, 95%. Do not have to be 100%. You can try non-invasive positive pressure ventilations. There is some evidence out there that this does work in drowning patients. There was a study that showed a good amount of the patients who were they avoided intubation by using CPAP or BiPAP. The main thing is that if there is no rapid improvement in the first 5 to 10 minutes, you need to go ahead and proceed to endotracheal intubation. For endotracheal intubation, patients who are not protecting their airway or a large amount of foam or emesis coming out, like I said, if they're looking bad up front, go ahead and start planning for endotracheal intubation because they can go downhill pretty fast. Mechanical ventilation, there's no large drowning-specific trials. Most recommendations follow the RNETS protocol right now, but again, nothing specific to drowning itself. Circulation, IV fluids to avoid hypertension. You can use vasopressors if refractory, but the main thing is reversing hypoxemia. Again, these patients get hypotensive from hypoxemia, also from a cold water diuresis, depending on the type of water they're in. But really, you need to optimize oxygenation to best prepare these patients. So accidental hypothermia. This comes out a lot because everyone wants to know, well, isn't cold water or hypothermia neuroprotective? Well, the problem is that is the exception, not the rule. There are plenty of case studies of very small children falling into icy water and surviving prolonged periods of submersion. There's submersions up to 60 minutes. There was recently a case study where a child underwent 88 minutes of CPR and then walked out of the hospital a few days later. But again, these are very rare cases, usually very small kids falling into very icy water and experiencing rapid cooling. Most commonly when a drowning patient comes in hypothermic, it's due to prolonged exposure to the water. It's actually a very poor prognostic factor. So especially when these people do not have a pulse or cardiac arrest, we need to utilize active rewarming to get ROSC and better serve the patients. So ED workup. So I'm going to try to demystify some of the workup here. There's really no specific workup to drowning. It's more based on the patient vital signs, their clinical exam to kind of guide your treatment. But in general, a lot of these patients end up getting a chest x-ray. It's important to understand that chest x-ray does not correlate to clinical outcome, disposition, or ABG. Some studies do show that those who develop ARDS down the road have an initial abnormal chest x-ray, but a normal chest x-ray up front really doesn't tell you much. Head CT, not too much prognostic value. A normal head CT cannot tell you anything up front. You really need 24 or 48 hours for prognostication. Those with an initially abnormal CT due to hypoxemia have a pretty poor outcome. C-spine injuries, like I touched on earlier, very low prevalence of C-spine injuries in drowning patients. Those who have C-spine injuries have a known high-risk mechanism: intoxication, ultramental status, obvious facial fractures. The main thing is do not let C-spine precautions obstruct proper resuscitation. But these patients can be evaluated with Nexus criteria or Canadian C-spine rule at the bedside to figure out if you need to do radiography or not. Laboratory testing, there's very little clinical value to laboratory testing. There were initial studies that showed profound electrolyte abnormalities, but those were in controlled environments in the lab where they're instilling massive amounts of fluid down the trachea, and also some studies done in the Dead Sea, but none of these ever showed any clinical value. They are indicated if you're looking for possible causes of the drowning, so if the patient maybe had a cardiac arrest or was intoxicated or had drugs on board, or looking for reasons for continued ultramental status, so continued hypoxia and other drugs on board. Antibiotics, currently there's no evidence to support empiric treatment. Again, the initial chest x-ray does not correlate with eventual pneumonia. These patients often have no opacity on the chest x-ray. They often have leukocytosis reactively, and they often have a low-grade fever. That doesn't mean they have a pneumonia. So they're best treated down the line with bronchoalveolar samples. So really giving them antibiotics up front doesn't help much, especially because anytime they develop pneumonia, it's usually highly resistant bugs that we need to tailor to the respiratory cultures. Other treatments, steroids were used a bunch in the past. There's no evidence of benefit or harm in drowning patients. They may be utilized in ARDS treatment or other treatments down the road, but nothing specific to drowning. And also diuretics used to be used due to concern for pulmonary edema, but this isn't a cardiogenic pulmonary edema, so there's no evidence of benefit, and the patients in general are likely volume depleted, so we could do more harm. ECMO is the big thing coming out in the evidence now. So there's little drowning-specific evidence. There's currently no evidence of harm, and these studies are very difficult because patients who need ECMO are cardiac arrest patients from drowning. And like I said before, these patients have terrible outcomes to start with. So very hard to study. It is currently recommended by the 2002 World Congress on Drowning, but this is based on very poor evidence. They are becoming big in centers that treat a lot of drowning patients or that treat a lot of hypothermia patients. And therapeutic hypothermia is the same thing. Very little evidence that's currently recommended, but based on very weak evidence. In general, if you resuscitate a cardiac arrest patient from drowning and you get ROSC, current recommendations are to try to hold the temperature at 33, 34 C for 24 to 48 hours for therapeutic hypothermia. And disposition. So what do we do with these patients? So the literature is very weak on disposition. 3 small studies, primarily pediatric and young adults, but it's the only literature we have and the only way to kind of guide our practice. So in general, if you look at it, what it says is if someone has a normal lung exam when they come to the emergency department, normal mentation, normal respirations, and normalized vital signs on room air, you can observe them for 4 to 8 hours on room air, and if everything remains good, they're good to go home. If they start to decompensate or have any changes or start needing supplemental oxygen or acting weird, or you just don't feel comfortable with their home support status, you need to go ahead and admit to inpatient. Now, if they have an abnormal lung exam, so again, crackles and rails in your initial lung exam, ultramental status or respiratory distress that are improving with treatment, or hypoxemia, hypotension, hypothermia that are all improving with treatment, these patients do pretty well on the floor. So again, they're a little sicker, but they're not really meeting ICU status, but they would benefit from observation in the hospital. And then obviously cardiac respiratory arrest, any of those ultramental status respiratory distress that's refractory to treatment, or hypotension, hypoxia, hypothermia refractory to treatment, these patients warrant ICU status. And then prognosis. This is what families always want to know. How is my child or how is my family member going to do if and when they wake up? So there's a recent systematic review, 24 cohort studies, overall low level of evidence. So there's not much to go on, but again, this is the best evidence we have. What it found and what every study to date has found is submersion duration. So the duration of time the person was under the water is the best correlator to prognosis that we have. In general, shorter is better. So less than 10 minutes, they tend to do better. Greater than 25 minutes, they tend to do pretty bad. And in between, we don't know. So again, every study that's of any quality has shown that submersion duration is the best prognostic factor. Other ones that have shown a little bit of promise are EMS response time and water salinity, but pretty much weak association. So the main one to focus on is submersion duration. It's tough because we often don't have a good story as to how long the patient was underwater. Things that showed no association in that study were age, water temperature, and witnessed versus unwitnessed submersion. So to wrap things up, first off, know the terms. We have to speak the same language. There's way too much variability to drowning terminology out there, and all it does is serve to confuse patients, confuse the family, and confuse providers when we're trying to speak with each other. Also, reverse the hypoxemia. That first and foremost, that is the number one goal of any drowning resuscitation. Keep that in the back of your mind. You have to reverse the hypoxemia. Do not let anything else get in the way of that. And third, think about the brain. This is a disease of the brain. Time is brain, so reverse the hypoxemia, save the brain. Some recommended references: the Emergency Medicine Practice. That's a review article I wrote back in May 2015. If you have access to this, I thought it was a very good article that kind of summed up all the current literature. We also have a treatment algorithm in there. And if you want an in-depth dive into this, Drowning by Joost Beerens, the second edition just came out. This is a large textbook dedicated to everything you could possibly think of with drowning. To wrap up, drowninglit.com, I review all the new drowning literature that comes out and try to link out to some other important, helpful topics. And I also have some copies of old video lectures and podcasts on there, so please check it out. And you can also contact me at any time through that website if you have any questions. I greatly appreciate you watching this, and take care.